Good morning, everybody. This is an exciting day 3 of Ladera Ranch, and we have Mr. Claude Triplett here. He's going to be our patient today, our live demonstration surgery, and as we discussed over the last couple days and this morning, the first thing that we did this morning with Claude, if I can call him Claude, is the consent form. And as we mentioned, we went over the Ladera Ranch consent form, which is more of a corporate consent, and maybe a little bit more involved than what you would want to use in your practice. But Mr. Triplett and I have discussed the potential risk. We're going to be doing tooth number 30. So the area that we're concerned with is the mandibular nerve area. But I assured him that we are so far away from the nerve that that isn't really going to be an issue here. As we discussed your individual cases, we have to be concerned with our anatomy. We spent a lot of time on anatomy yesterday, and we want to make sure that we're in the proper position. What's nice about the protocol is that it's written down for you step by step, and we are going to go very slow. We're going to go in 1 millimeter increments, and we can stop at any one point and take a radiograph. So Mr. Triplett, we're going to do tooth number 30, and he has no serious health conditions. He does have high blood pressure, which is controlled with medication, and he did have a hip replacement that we're not overly concerned with today. So what I need to do first is ask Mr. Triplett if he has any questions.
None.
None. Okay, he's very relaxed and very comfortable. And what we're going to do is we're going to go ahead and infiltrate the site. So we're going to reposition the camera, and I'm actually going to do it live, and we'll wait 10 minutes and let him get numb, and then we'll get started. So I'm going to move my position. Before we do that, Belinda, can you get close to this? Can you zoom in, or? Mm-hmm. Okay. We all reviewed our CT sheet that we gave, which gives us a lot of information. We have a panoramic that has no distortion on it, so we can actually see the vital anatomy. We have a bone model so that we can actually see the contour without soft tissue. And then we have 2 millimeter cross-sectional areas. We reviewed this in detail yesterday. And from the crest of the ridge to well above what we perceive to be the mandibular nerve, or the foramen for the nerve, we have 16 millimeters. So we can certainly place a pretty long implant. However, look at the concavity on the lingual. We want to stay away from that area, obviously. So we are going to palpate and make sure that we clinically determine the position of the bone. Our width of bone is over 8 millimeters. So in our preliminary determination of the implant that we want to use, we can certainly put a wide implant. We could put a 5 millimeter diameter. We can move down to a 4.1. And the length we're going to finally determine using our radiographs. But right now we're probably looking at an 11 millimeter implant that can be safely placed in this gentleman. The other thing that you all looked at is mounted casts, and Mr. Triplett has a partial on his upper ridge, but we certainly appears on the model to have adequate width of bone. We also have great attached gingiva. Dr. Engel alluded to that yesterday about how important it is to have attached gingiva, and if we don't, we certainly have to create it. Because he has a partial on the top, our interocclusal distance isn't going to be an issue at all. Are there any questions? No questions at this point. Can I have a clap? Okay. So what I'm going to do now is anesthetize the area, and we'll move forward from there. You okay? Great. We're going to infiltrate the area with articaine or septicaine. We're going to try to give you a good position here. I apologize if I'm pulling too hard. If I do, please raise your hand and I'll give you a little breather. We're going to work on tooth number 30 area. No, sure. That's fine. Okay. So let me go ahead and infiltrate. Now my staff has already put topical on there for the last 10-15 minutes. So maybe just a little mosquito pinch. You okay? You all right? Okay. And we'll just infiltrate the area. Sure, take this, please. And we'll just give that a few minutes. And then we'll actually inject a little bit on the crest of the ridge to anesthetize the soft tissue. Remember what we said, that bone is not innervated, there's no pain receptors there, so the only thing we're trying to do is to really numb the soft tissue. Still with me? Okay, great. Go ahead, you can do it. Yeah, that's right. Let's do that first. Okay, the next thing that we're going to do, and I'll come to you, Belinda. Okay.
You want to show them you go to gingival line.
Oh. All right, let's do that. Open for me. Okay, Dr. Engel asked us to show you guys the mucogingival line, and again, I apologize for stretching these so much. Let's see if we can use this side. Sherry, can you rise, please? Is it standing on the screen? No, I want you to zoom in. I just want you to move it up, so it's up the other way. There you go. Perfect. Perfect. Okay. Our mucosa ends at this point right here. If you can see the crown on number 29, we certainly have attached gingiva. At this line angle. You have a mirror there, Sherry? Thank you. You may have to retract. What? Okay. Can you retract this, please? And we'll try to get a mirror shot of this if we can. So we have a nice wide ridge, and our implant position is going to be a little towards the lingual, about in that position. And if you remember, we minimally want to be 2 millimeters from the adjacent root. That's minimal. But again, we're going to be putting a molar tooth here, so we can go a little more distal, but we're certainly in attached gingiva. An ideal situation for a flapless procedure. Alright, now I'm going to give Mr. Triplett a little more anesthetic. This might pinch just a little bit on the crest of the ridge, kind of walking up. Beautiful. And we can see the tissue blanch. Very good. We'll go ahead and rinse that, Sherry. Now at this point I tell the patient, you've been through the worst, okay? So that's the hardest part. We're going to give that a few minutes to get nice and numb for him. So the next thing that we're going to do while we're waiting for anesthetic is we have the 5 millimeter diameter ball bearing in ortho wax. And now he's edentulous in the posterior, so we're going to try to lock it in. Open for me, please. I'm going to try to lock it in a little bit around the adjacent teeth, just to get that DEXIS measurement for those of us that we would not use a CT scan. Okay, and a mirror again, please. And open for me, and we can see the ball bearing in approximate position of where we want the implant to be. So we'll stop right now, and my staff will take a radiograph, as they will for your patients. I'll hold it, Sherry. Open for me, please. Go ahead. Okay, let's do one more, Sherry, because we cut that off a little bit, okay? I need to go a little bit higher. Sorry about that, sir. And lift your chin up just a hair. There you go. Perfection. Okay, go ahead. Okay, great. I'll take this out for you. We're just waiting for the anesthetic to take effect, okay? We're going to turn the camera around and show you the DEXIS screen, and then Kristen is going to show you the measurements, and we'll determine what length of implant that we want to put in there. So, Linda, if you can do that, please. Please go do the measurements. Sure, that's okay. So what we want to do is, we know the ball bearing has a definite diameter, and with most of the digital x-ray programs we can measure that known entity. And she's just drawing into the circle.
Fully gauge. Okay, I just saw you on the implant.
From the crest of the ridge.
You got to calibrate it. Did you calibrate it?
That's fine.
There's a green line around it? Mm-hmm. Cool. I'm going to go back out there.
Okay. Crest of the ridge to about the apices of the adjacent tooth. From there, start there, and pull it down. Straight down, little bit more, little bit more, little bit more, little bit more, right about there. Okay, so when we're looking at the numbers here, if we're looking at the DEXIS program, what we did was trying to determine the length that the vertical height of bone that we have. It's not giving us width, obviously, and we're taking it from the crest to approximately the apices of the adjacent tooth. And we'll have a measurement of approximately 10 millimeters. Now, we also had the CT. We know we have a lot of room to work with, but this is the exercise that we want to leave you with. We can go slow, and we're going to have a variety of implant sizes, widths, and lengths, and we're going to go through the process and determine what the best length of implant is for Mr. Triplett. So as of right now, maybe we would want to stop with a 9 millimeter implant, but potentially we want to go to an 11 millimeter implant, but I want you to feel comfortable with the anatomy and where you're going when we're not around to guide you. Okay, let's turn back around to the patient. So the first drill we're going to use, or the first burr we're going to use, back off just a little bit, Belinda, if you could, on the burrs, please. Okay, is the Lindemann burr, and as you recall, it's a very sharp, pointed burr. It does have markings on it of 7, 9, 11, 13, but that's not so critical. Because what we're going to do is we're going to just go maybe 3 millimeters into bone. So we simply have a latch, and here's our burr. This is where we're going to determine our initial parallelism. So let's go back. Are you ready? Okay. If anything I do bothers you, please just raise your hand and I'll stop, okay? You're going to feel some vibration, but nothing of any significance. Okay, so the intent, need to get a little closer, chin down just a hair. There you go. There you go. I think we can see that pretty clearly. You can't see the distal aspect of the tooth, but you'll have to trust me here. So we're going to use our Lindemann burr, which is very sharp, to penetrate the cortical plate. Just go into 3 millimeters into bone and determine our angulation. We are going to be putting a molar tooth here, so we don't want to be 2 millimeters from the adjacent tooth. Rather, we want to create a nice shaped molar tooth. If you can open big for me again. And I'll try to do this so that you can see, kind of moving my hands a little bit, where I would say we're probably 6 millimeters from the distal aspect of that adjacent tooth. I'm asking my assistant, does that look pretty good to you, Sherry? Yeah. Okay. I'm looking at the buccolingual and mesial distal position. I'm looking at about 9 o'clock right now, and we're just very, very slowly going to pump and cut through that cortical plate. Now, as we talked about yesterday, when you go through that cortical plate, you can feel the resistance, and once you pass through that, once it goes through that cortical plate, there's less resistance. And we're simply going to put a pin in here so that it's stable. Try to use my left hand here. And we tell Mr. Triplett that we do have a pin in your mouth, so we can't have you close. Okay, I'm going to take a quick x-ray. Okay? Okay, don't close down. We'll do this kind of quickly. Sherry? Okay, stay with me here. Thank you. And go ahead. Go ahead and relax your jaw now. Are you doing okay?
Sure.
The hard part's done. So let's look at what we did. We were pumping up and down, millimeter. I'm sorry, Linda, can you? Maybe it's this time. Good. So let's look at the x-ray again. And we took our Lindemann burr, pumped it up and down. We broke through the cortical plate, 2-3 millimeters into bone, and we're determining our angulation. Now, that's pretty good, I think. Maybe we could take the coronal portion and move it distally slightly with our next pass. But I think we're in pretty good position. Using that adjacent root as a guide is very, very important, and it's going to be impossible for you to make a mistake when we use that adjacent tooth as a guide. You want to ask him if he's good, or should we move on, or does he? We're good? Okay, come on back to me.
Okay.
So we look pretty good with our angulation. You want to suction it just a little bit. And you can see my entry point quite clearly, about right there. Okay. And we're a good 6-7 millimeters from the adjacent tooth, which will give us a nice contour. Now my plan, according to the CT, was to place a 4.1 by 11 Cybron XRT implant, and we're going to sound the bone here, or sound the tissue, I'm sorry, to see how much soft tissue we really have. And it's thin, as you would expect. You know, maybe, can you pull down a little bit, so she can look at the screen and you can see what we're looking at? Yeah, there you go. So we're pretty thin in the bone. So what I'm going to do is I'm going to go to depth with my 2.2 drill. We're going to place an 11 millimeter long implant. We have approximately 1 millimeter of soft tissue, so we're going to go to 12 millimeters. Pan down a little bit so we can do it on the bib, please. There you go. Okay, so this is our 2.2, and again, you can see the marking, 7, 9, 11, 13. So we're going to end up about the middle of the second black line. And then we'll stop and take another radiograph at that point. Sir, are you still okay? Searching for me? Close just a hair. Here you go. Oh, that's beautiful. The mirror doesn't. Is that the mirror that I'm looking at? Okay. So we're coming back, and I'm going to angle this just distally, slightly. I know that's hard for you to determine. And just pumping, copious amounts of water. Here we're at 7. 9, 11, and about 12. No problem, sir? Beautiful. We'll take our 2.2. Pull that much. Suction, please, Sherry. And you can see we're at about 12 there. So we're going to stop and take another radiograph and see exactly where we are. You have a pin, so don't close down. Okay, go ahead. Go ahead and relax. Linda, you have to go on that screen, please. So let's look at what the 2.2 burr allowed us to do. We can see the measures, 7, 9, 11, 13. It looks like we need to go a little bit deeper, but I think we're in really nice angulation and nice position away from the adjacent tooth. So what I'd like to do now is punch the tissue so that I can actually see the depth of the soft tissue.
Doctor said you're doing a pretty good job.
I've done it before. Does everybody agree that we're in pretty good position? Can I have a clap if you do? I didn't hear Dr. Engel clap. Okay. Come back on the bill, please. So in your surgical kit, you're going to have a tissue punch, and we showed this yesterday. It's really just a circular blade that's going to allow us to remove the tissue over the initial osteotomy site. We don't want to put epithelium down into the socket, so we're going to remove that soft tissue. For me again, sir. You okay? Open. And close just a little bit, sir, just a hair. There you go. Beautiful.
Open a little more.
Other end. Start opening it up. Just look at the picture, sir. And we're going to go to our site, and I'm simply going to kind of rotate it around. I'm actually trying to cut the soft tissue. Through bone. I'm using a little bit of force here. And we'll just take a periodontal instrument, a jacket. Grab it with a tissue paper. Hold on, sure, watch your hand. Okay. And, come on down.
Right now, if you can demonstrate doing a tap.
The tap?
Yes.
Sure. And here's the little tissue plug. Now let's go back to the side. Can we see that pretty clearly? There's our osteotomy site. A little bit of bleeding from the soft tissue, but looks like we're in pretty nice position. Take a little breather, sir. So we showed from the latest radiograph that I wasn't completely to the depth that I wanted. So open for me again, please. So I'm going to go back with my 2.2. But before I do that, I'm actually going to measure that soft tissue, and it is 1 millimeter. So let's make sure we're at the depth that we want for a 4.1 by 11 implant. Still with me, sir? Mm-hmm. I'm just going to go a little bit deeper here. What's holding me up here is as you saw in the video yesterday, the handpiece is actually stopping on the tooth as I'm demonstrating this. So I'm going to try to use the extension. Can you back off a little bit? And see if I can use the extension to keep the handpiece away from the adjacent tooth. Sometimes you can't use this in the posterior, in the mandible, because there's not enough room. But let's see where we are. Okay, good. Just a little bit deeper there. We'll reinsert the pin, a little bit deeper length. We'll stop and take another radiograph. Get a pin in your mouth again, sir. Go ahead. Go ahead. And I'll take that out, and you can take a little breather. Okay, can you go back to the video, please? Okay, so this is the 2.2. Went a little bit longer than the apices of the adjacent tooth, but we're in good bone. And again, we had the insurance of the CT that said we had nearly 16 millimeters of length there. I think we're in pretty good position. So we're going to move on to the 2.8 twist drill. The 2.8 will create a space for a 3.3 diameter implant, and then we'll stop and take another radiograph at that point. And the 2.2 again with the same markings. Sorry, to open the signature can. Good. Again, pumping up millimeter at a time till about 12. We'll come back, place our pin in, take another radiograph. You have a pin in your mouth again, sir? That won't work. And open again, sir. Okay. So let's look where we are. With these burrs being notched, 7, 9, 11 is where we want it to be. I'm slightly longer than the apices of the adjacent tooth, but this is a very, very short tooth, and we're nowhere near any anatomy. So the next drill that we're going to use is the 3.5 diameter twist drill, which will be our final drill in preparation for a 4.1 diameter implant.
You want you to blow on the X-ray. Double click on it.
We're nearly done. Okay, pretty cool, huh? Okay. All right, so what we're looking at is 7, 9, 11. We're in pretty good position there. Are we okay to move on? Okay, so again, let's go to the bib here, Melinda. Here's our 3.5 diameter twist drill. which will undersize the osteotomy site to accept a 4.1 diameter implant. And again, pumping up and down, 1 millimeter increments, but there's very little resistance here. I think I could have gone just a little bit deeper there. Now, as you're doing this on your patient today, we're going to stop and check this and be very conscious of it. Go ahead and touch this. Okay, let's do another radiograph. You have a pin in your mouth again, so sorry. Okay. So looking at this radiograph, this is our final drill radiograph, 7, 9, 11. We're a little bit subcrestal here, a little supracrestal here. You can see the soft tissue, which is pretty thin in that area. And how's our patient doing, okay? Great. Now, Dr. Engel asked me to demonstrate the bone tap, okay, and you can see there's threads. This is a 3.5 diameter bone tap in preparation for a 4.1. Now, what I'm going to do is I'm going to slow down my handpiece to 35 revolutions per minute with no water at this juncture, because I just want to show you, I don't want to make a mess. And you can see how slow that rotates. Todd, I'm not going to tap the bone because the bone was not real dense here. But I just wanted to demonstrate it. And what you would do if we went to the mouth, and I'm not going to tap the bone, but just to show you, is we would go to the site, and very slowly, we would be using water in this situation in the mouth, but just for the sake of not making a big mess. Okay. Do we have a 4.1 by 11? Can we show it to the camera, please? Sherry is holding a, on the bib, please. The box for a 4.1 by 11 millimeter long L Cybron implant. It's internally with an internal hex design. So she's going to go ahead and open that, or Kristen will open that. And then Sherry will show you the internal packaging. And again, package sterile, 4.1 by 11. Go ahead and open it. And show them again the markings. Then the internal packaging, again, is marked with the same. In the box, there's little stickers. Can you pull those out for me, please? And in the box, there are little stickers that list the catalog number, the lot number, and I would keep these as a record of your patient. If anything happened, it's nice to know which implant you're used, at what time, and what year. Okay, thank you. Now, Sherry, if you could crack that open, please. For the camera, please. For the camera. And Sherry's just going to pop that open and show the internal design of the implant. Okay, fantastic. All right, and then separate the red and show them the cover screw. And what's unique about this system is it does come with a cover screw inside the. It comes with the implant itself. Okay, Sherry, if you can bring the implant to me. So here we're taking a 4.1 driver, hex driver, and we're going to simply place it in the implant. Okay, and we're going to be careful here. Okay, now. This is solid. It's not going to come off, but if you bump it or something, it could. I have the handpiece set at 11 to 35 RPMs at 25 Newton centimeters of torque. But I'm not necessarily just going to put the implant in until it stops. I'm watching the implant slowly go into the bone. We're going to stop at the tissue level, and then we'll hand tighten from there. No, just stay there. And you can see the short revolutions there. And I'm just watching it. Suction, please. Don't touch the implant. That's it. And I'm watching it. It's at the tissue level. So let's go ahead and we'll take a radiograph of this. We know I want to go a little deeper, I want to go subgingival, but let's see where we are, where the handpiece stopped. Go ahead. Okay, we're nearly at position. But we'll go ahead and we'll demonstrate the hex tool. All right, good. So let's look at the torque wrench. Maybe a little closer there, Belinda, maybe? Yeah. We can see there's an arrow that's pointing towards me. Linda, can you get a little closer, maybe?
Mm-hmm.
Yeah, it's just because it's metal. The arrow is pointing towards me. If we wanted to back an implant out, we would simply pull this little knob and turn it so that the arrow is pointing away from me. We'll turn it back so it's pointing towards me. And here's the wrench. We're going to place the implant at 15, 25, or 35 Newton centimeters or more or less, and whether we put a cover screw or a healing abutment will be dictated by the amount of torque we have. We have a hex tool that will simply fit into the torque wrench. We'll create a point on the head, and we will only use the little knob to tighten.
Open? Thank you.
And as you can see, there's very little bleeding at this point, and we're just about done. So I'm going to set my hex tool in position. And Sherry, I need your other hand to hold on to the retractor. Okay? Thanks. Putting a pivot point here. And I'm just going to go a little bit deeper. We're at 15. And we're going to get to 25 Newton centimeters. Everybody can see that. Okay, so let's stop and take another radiograph and see the position of the implant, if we need to go deeper or not. Open for me, please. Go ahead. Okay. Do we think we're in good position, or should we go a little bit deeper? Can I have a clap if we think we're in a good position? Okay. So we did get it to 25 Newton centimeters, and we're going to go ahead and put the healing abutment on next. Okay, and if we come over here, and Sherry will hold the packaging for the healing abutments. Sir, the implant's in. We're done. We just have to take one more x-ray and we're finished. So this is the packaging. We're going to use a 2 millimeter tall or high healing abutment. It's a 4.1 hex. And go ahead and open that, Sherry. And here we have our hex tool. Yeah, go ahead and show that. Here's the internal packaging. Everything is very, very consistent. Go ahead and open that for me. And can we look a little closer, maybe? You can see that's 2 millimeters height of tissue. It will go inside the implant, the internal hex, and we'll simply take our hex tool. And again, we want to be a little bit careful with this. As you do more in implants, things do wear out a little bit. It's solid. It's not going to fall out, but always be a little careful as you're going to the site. For me, sir. And again, little or no bleeding. Hold that mirror just a little bit differently. Can't really see what we need to see. There. And we're going to go to site carefully. I'll try to do this where you can see it. Can you pull that out, please, Sharon? Thank you. And we're threading the abutment into position. And then what I'll do is again go back to my torque wrench. Sherry, can you hold that, please? Again, having a purchase stop and just tightening to 15 Newton centimeters. This won't come out. It'll stay in there until integration is progressed, and we are all set. Let's hold that just real quick here. Center of the ridge, and let's go ahead and take our final x-ray. Okay? Okay, we're done. And open for me, please. Thank you. Sorry. Chin up just here. Good job. Go ahead. So we're in a nice position. The patient didn't respond to any symptoms during the procedure. Obviously, videotaping and opening as long as he did, I truly appreciate that. You can see what we talked about yesterday as far as the concept of platform switching. The implant is at the crest of the bone. The healing abutment is in the internal design of the implant body itself. We're parallel to the adjacent root. We torque to about 25 Newton centimeters. We'll allow 3 to 4 months for integration to progress. We'll take our impressions and finish this case. Is everybody satisfied with what we have? You give me a clap. Okay.
One for the patient.
Can we have a clap for the patient?
I'd like to interview the
Yes. Go ahead and go to. Now, something that I've done routinely for the last 26 years is anytime I do a surgery, whether it be an extraction or an implant, I will infiltrate with dexamethasone sodium phosphate, 4 milligrams per cc, and I will simply infiltrate 4 milligrams to the site. Dr. Engel talked about Medrol dose packs for 4 days, and certainly that is another option. But this eliminates swelling and discomfort in all our patients, and I routinely use it with all our surgeries. Open 22. This is just a little steroid that we use that'll keep the swelling down. And what we simply do is I'm just going to the site and adding a cc of material. Okay. You can relax. Is your jaw okay?
Oh, yeah.
Okay. Very good.
No
Can
problem.
you take his sunglasses, please? We're going to take your glasses off. Yeah, we'll give you a rinse. And you know what? Let's, yeah, go ahead and rinse and just one more. Let's just look at the site one last time that Sherry was able to rinse it. And this is what you're going to see. Go ahead and get a close-up of that, please. Good. There's no bleeding. And the patients really don't experience a lot of discomfort. Now, in my post-operative discussion with the patient, we talk about antibiotic therapy. We talked about that before. That's just a precautionary thing. We want to make sure that there's no infection or anything like that. We did give you a narcotic for pain, but you probably won't need it. As you could probably tell, this went a lot simpler than you could have even imagined. And most of our patients will only take extra strength Tylenol for any mild discomfort. And it's really just soft tissue. The soft tissue heals very, very, very quickly. The most important thing in these procedures is that we direct you to use ice to your face. And ice is very important to keep the swelling down. And I'll tell my patients to use ice until they go to bed tonight. 20 minutes on, or it's too cold, take it off for a little bit, let it warm up, and put it right back on. If we don't have swelling, we don't have pain. If we don't have any pain, it makes me look very, very smart. So, Belinda, if you can just pan back, and I'll move, and we'll just do a little conversation with the patient. Well, Mr. Triplett, we did great. Thank you so much for being so patient with us. And we have the camera over here, if you want to kind of turn your head a little bit. And can you pan down just a little bit to get Mr. Triplett? Yeah. There you go. And so, were you anxious before we started?
Yes.
Yeah. And did we do a good job of explaining what we were going to do?
Very good.
Was it easier or harder than you thought it would be?
Easier.
Easier?
Yes.
Did you feel anything at all other than the initial injection?
Nothing.
Okay. So it was a good experience?
Very.
Does anybody in the audience have a question for our patient before we excuse him for the day?
Good.
Thank you so much.
No problem.
It's outside.
We're good. No questions. Well, again, thank you, sir. I hope this was a pleasant experience. We're going to allow it to heal for 3-4 months, and I'll see you next week just to say hello and check on you. Okay?
Right.
Thank you so much. I'm going to let the staff take over.
Okay.